Good morning. Case study presentation. Nursing 374, Section 1 by Lance Ganter. So in this case overview, a senior anesthesia resident working long and stressful hours, most likely suffering from improper rest, administered a lethal dose of insulin. The patient eventually expired, but the death was result of deteriorating health, not the actual dose of insulin. So what went wrong in the case? In this, the anesthesiologist did not utilize a double check with his attending. There was no verbal readback confirmation on the order, as well as on the amount of medication to be administered. The resident was apparently suffering from mental exhaustion from a previously long surgery. Issues continued. Was the senior resident in violation of working more than 16 consecutive hours? If so, this shift would have been outside the purview mandated by the Accreditation Council for Graduate Medical Education. This mandate states that single shifts are reduced from 30 hours to 16 working hours. This is intended to improve patient outcomes, reducing fatigue for physicians. Issues continued. Now, were the labs drawn prior to surgery being scheduled? If so, what was the potassium levels prior to the patient heading to surgery? If the levels were abnormal, why was there a delay in correction? Because we know that hyperkalemia is considered a contraindication to anesthesia, as it may predispose the patient to cardiac dysrhythmias. So how could this issue be resolved? 1. Proper rest for any medical provider. It's essential to one's mental and physical well-being. 2. Could the senior resident have delegated this procedure to a junior resident due to the senior resident dealing with his own fatigue? 3. Prior to administering critical medication, double check should be instituted regardless of position. And 4. Provide electronic scanning with verification software for proper dosing. What role do other disciplines have in resolving this issue? 1. The attending was at fault for not promoting double checks with residents, especially after residents working long hours, which leave them obviously fatigued. The senior resident was also at fault for not verbalizing a readback on that order. And pharmacy needs to provide more manageable solutions to providing an insulin for IV injections. Proposed solutions. Institute a facility policy. Mandatory verbal readback with team members upon administering high-risk medication, regardless of medical title. Enforce residents working no longer than 16 hours in order to minimize fatigue. Require medications to be scanned prior to administration in order to reduce errors. Lab values to be closely monitored prior to any surgical procedure, and if not correctable, formulate workflow for emergent dialysis. What barriers existed during or could exist during implementing proposed solutions? 1. Scanning of medications by anesthesia, especially in emergent situations, may be problematic. Enforcement of a 16-hour rule by the ACGME could pose to be challenging, especially in emergency situations or during mass casualty incidents. Residents may feel leery or intimidated to initiate verbal readback with their attendings. Solutions continued. Insulin for IV injection should only be available in 1 unit per 1 cc concentration. The institution could implement a root cause analysis to be conducted with all involved participants as well as impacted departments. Lastly, implement new processes within 60 days in order to reduce further medication errors. I hope you like this presentation. Any feedback is welcome. Thank you.